Hello, my name is Rahul Sheth, and I am an interventional radiologist at MD Anderson Cancer Center in Houston, Texas. In this presentation, I'll discuss the range of image-guided local therapies that can be applied for patients with oligometastatic renal cell carcinoma. These are my disclosures. So image-guided local interventions for patients with oligometastatic renal cell are well within the standard of care, and you can see here from this capture of the latest NCCN guidelines that they're indicated along with surgery as well as radiation. In this talk, what we'll do is go one by one through the most common sites of metastasis for renal cell carcinoma, and then discuss what the image-guided treatment options are for each one of these. One thing you'll notice is a recurring theme for many of these sites, and that's the use of combination approaches to help maximize the ability to get local control as well as to palliate symptoms. But before we dive into it, I wanted to first familiarize everyone with what it is we do in interventional radiology. So we perform image-guided procedures, and one of the most common ones we do is tissue sampling. So for example, with some of the advances in image guidance technology, we can now perform biopsies from just about anywhere in the body. And in addition, we can also offer a wide range of minimally invasive therapeutic procedures. So these procedures include things like transarterial embolization, as well as radioembolization. We can also destroy tumors with either extreme heat or extreme cold through technologies such as microwave ablation or cryoablation, respectively. So the lung is the most common site of metastasis for renal cell carcinoma, and while radiation and surgery are the mainstays for these lesions, there's also a growing role for thermal ablation. So in general, we prefer to perform ablation in lesions that are smaller than 3 centimeters and lesions that are not immediately adjacent to central blood vessels, such as in the hilum. The outcome for ablation for renal cell metastases in the lung is actually excellent, and in several retrospective series of 100 lesions, you can get about a 90% local control with 5-year follow-up. The most common complication for lung ablation is pneumothorax. However, this is generally very easily managed with just a temporary chest tube following the procedure. Bone metastases are very common in the renal cell, and they're often a major source of morbidity for these patients. Fortunately, though, there's an extensive toolkit of image-guided procedures that can be applied for these patients. So this includes procedures such as preoperative embolization. We do this for patients who are going to the operative room, and this helps substantially reduce the intraoperative blood loss. We can also achieve local control of metastases involving the bone with procedures such as thermal ablation and arterial embolization. Likewise, it's often useful to have adjuvant maneuvers such as cement augmentation for patients who have lesions that are involving weight-bearing bones to help alleviate pain with weight-bearing. So as an example, this is a hypervascular metastasis involving the right humerus. And in this initial angiogram, you can see avid arterial enhancement, and this is a very common finding that we see with renal cell metastases. Following microsphere embolization, you can see that we've essentially completely blocked all blood flow to the tumor, and that led to substantially decreased blood loss in the operating room. This is an example of a patient with a left ischial metastasis. And to treat this, we used a single cryoablation probe advanced along the long axis of the tumor. After cryoablation, the patient had excellent immediate local control, and now 4 years following the procedure, she still has excellent local control without any evidence of local recurrence. Similarly, you can see this lesion here involving the anterior acetabulum. We treated this with cryoablation, just as the other procedure, but because it involved a weight-bearing portion of the bone involving the anterior acetabulum, we also delivered bone cement to this site immediately following the ablation, and this substantially helped improve the patient's symptoms of pain with weight-bearing. Continuing along this theme of combination approaches, this is a large lesion involving the scapula, and because of its size, we elected to proceed with both transarterial embolization, as you can see here, followed by cryoablation, which you can see here. With the combination of the two procedures, we were able to achieve excellent local control, and 2 years later, this lesion remains completely treated. Large complex lesions often call for a combination of multiple techniques. So for example, this is a large metastasis involving the left hemipelvis. And in this case, we elected for several interventions that were performed simultaneously. The first was transarterial embolization to devascularize the tumor. We then performed cryoablation. And if you've never seen a cryoablation before, you can actually visualize the ice that forms along the tip of these needles as this hypovascular oval surrounding the needles that we placed. This is how we can actually visualize the ice with our imaging, and that's helpful not only to make sure we cover the entire tumor, but also equally importantly to make sure that we don't extend the ice into normal structures and prevent them from getting injured. Following cryoablation, we then delivered bone cement right along the portion of the tumor that's involved in the acetabulum to help with the weight-bearing status. So we published our experience with local control for patients with oligometastatic renal cell carcinoma that involves the bone. We found that the overall local control rate was about 82%, but then when you look specifically at the patients who had oligometastatic disease, they ended up faring much better with a local control rate of about 96%. The liver is a not very common site for metastasis from renal cell, but the complications that can occur from these liver metastases are often devastating. And so we take a fairly aggressive approach at treating these lesions. This approach is also often benefited by the fact that the liver has a dual blood supply. So we can be reasonably aggressive with our transarterial embolization and still preserve blood flow to the normal liver parenchyma. Likewise, injured hepatocytes can regenerate, and so ablation can be performed fairly aggressively here as well. When there's small lesions and a small number of them, ablation alone is typically sufficient for local control. If there's multiple lesions, embolization is often useful, particularly given the fact that renal cell metastases are hypervascular, and so it's straightforward to target them with transarterial techniques. When they're large, though, both ablation and embolization can be combined to get local control. So as an example, this is a patient with a large, approximately 7-centimeter metastasis involving the right hepatic lobe. We treated it first with transarterial embolization. As you can see here on this angiogram, the tumor can be very specifically treated given the arterial perfusion of the tumor relative to the background liver parenchyma. In this case, because the patient's tumor was sensitive to doxorubicin, we performed chemoembolization by delivering microspheres that elute doxorubicin. This was then followed by microwave ablation, and if you've ever seen one of these procedures, this dark oval surrounding one of the ablation probes is actually steam, since we heat the tissue to greater than the boiling point. And at 1 year follow-up with a combination of these procedures, you can see the lesion remains under excellent local control. Similarly, this is another patient with a very large liver metastasis, and we treated this in the same manner, combining embolization with ablation, and 2 years out, the patient remains with excellent local control. Lastly, the lymph nodes are also amenable to local image-guided therapies. They can sometimes pose a technical challenge since they're often quite close to normal structures like the bowel or the bladder or nerves. However, there's several maneuvers that we can perform in a minimally invasive manner to temporarily displace the normal structures away from the tumor so that we're able to treat the lymph node safely. So as an example, this is a patient with a retroperitoneal lesion, and as you can see, it's immediately adjacent to several loops of bowel. However, we're able to displace these loops of bowel using saline and carbon dioxide through a needle, and that way we were able to create a safe buffer zone, and we could perform cryoablation of the target lesion. And in such a way, we were able to achieve excellent local control of that lesion with it essentially completely involuting while preventing any injury to the adjacent bowel. So in conclusion, interventional radiology has a wide range of image-guided procedures that can be used safely and effectively to treat patients with oligometastatic renal cell carcinoma. There's, of course, a long history of these procedures being used for local renal cancer in the kidney, but with a little bit of creativity, they can also be applied to sites of disease throughout the body. And in order to maximize the effectiveness of these procedures, combining multiple image-guided procedures can often be a very valuable approach. Thank you very much.